Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jean Sarnowski, and on today's program we're going to learn a little bit more about palliative care and what that is exactly. And we're lucky to have with us today Donna Dragos, who is a clinical liaison for the VNA's hospice. So thanks, Donna, for being here today. I appreciate it.
Thank you for inviting me, Jean. I'm really happy to be here.
This is good. It's good information.
Yeah.
I'm always like to start for the viewers of what your history is, how long have you been on the Cape? Did you have an early moment of this is the field I want to go into and this is why?
Well, I have a lot of experience that kind of culminates in hospice. I was a cancer researcher at the Marine Biological Laboratory when I first came down here in Woods Hole, which I was like, where's that? But then after 6 years, I went to nursing school and became a nurse and worked. I've worked at Cape Cod Hospital for a number of years, and in that I have seen that I have a kind of pioneering spirit, and I've seen that there's room in hospice and palliative care to grow. So I decided that when the time was right, I would transition over. So here I am, and I've never regretted it.
And lucky for us.
Thank you.
So I know the viewers have seen a lot of information, I think, about hospice and palliative care. So we'll just start with what is hospice care?
Well, hospice, when you think of hospice, the thing that you should think of is comfort, because hospice is about comfort. It's not a place. It is a philosophy, although hospice can be used as a place, but we'll think of it as the philosophy of comfort. So whatever it is that you're going through, the terminal disease that you might have, you have to fit into a hospice in order to come into hospice. You can't just decide it's time to go in. You have to fit in with a certain
criteria.
Yeah, and we have certain criteria that we use. And once you do fit into that hospice criteria, if you choose, there's a lot of things that can help make that transition, that end of life transition, much more comfortable. It can go on for periods of time, but whatever time is there, we make it a lot more comfortable.
Okay. Now, people can receive hospice care at home, as you mentioned, and I think there's still that image or that language that people think of hospice as a place. So it's back to what you were just saying, that no, it's actually a philosophy of care, and one can receive hospice care wherever they call home.
Yes, that's right. There are regulations that we have to follow like anybody else, but we work very hard to get hospice in to the patient that needs it. And that can be any place that they call home, yes.
And that would be like your house or
in a facility.
Assisted?
We need it. Mostly we need to work with a caregiver. So if there's a caregiver that works with you at home and you want to stay home, then we will work with them. If there is no caregiver and you still want to stay home, then we work with you to obtain a caregiver. We supply some kind of care in the home depending on what's needed, and we supply a nurse 24 hours a day, 7 days a week for availability for symptom management.
Okay.
But the actual care, 24-hour care, is a caregiver that is either a friend or family member or supplied by the person themselves.
Oh, okay. But they could be in an assisted living and receive hospice care?
Oh, absolutely.
Independent living?
Yes, yes, and actually more assisted livings are trying to hospice patients in place and keep them in place.
Yeah.
So we work very closely with a lot of the assisted livings to make that happen. And there's just a variety of different techniques. Every family is different, every situation is different. So we bring in what's needed to make sure that that patient is comfortable working with the doctor and working with the caregivers and working with the facilities.
What are some of the benefits of receiving the care at home?
Well, most people they've surveyed want to be home. They want to be amongst their things, amongst the things that they've had all their lives, their pets.
Their pets, I would think that would be a biggie. Yeah.
And the quality of life is what we're after. So if quality of life is at home, which it is for most people, then that is the main benefit. We can work anywhere. But again, the home is, and also I always say it's best because even if there's a friend or family member or, daughter, whatever, that can, son, or anybody that steps forward that's comfortable doing it will work with. But even if they have to hire privately, I say, you can't send your family member around the world on a fabulous vacation, but you can give them this nearing the end of life. You can give them one-to-one care, even if it's just overnight so you can sleep, so you don't have to be that caregiver. You can be the spouse, you can be the daughter, but you can supply the caregiver who is there anytime they need it. It's not like you wait your turn or anything like that. So that is what I call the special situation where it's nice being at home, and I'm hoping for that myself. I hope my daughter's listening.
I think of that too with pets. I see so many people with pets, and you wonder, they're just such a big part of their life that they can't leave them behind and go into someplace else. Staying home would always be the best.
That special bond between a pet, I totally understand that. It's lovely to see.
Yeah. And it does a lot for the person.
It does. It does. It's that quality of life at the end. And as they say, people are on hospice care, and we'll talk about, and palliative care, we'll talk about that pretty soon, statistics have shown that they live longer.
Oh,
and
really?
I think that's it. We bring in, we'll talk more about what else we bring in, but one of the things is having that quality of life.
Yeah. So let's move into that then, palliative care. So we touch on hospice a little bit. Now, as palliative and hospice always seem to be terms that go together.
Yes, and it's confusing. There are different people use them in different ways, and I want to try and explain that a little bit for the people at home. Palliative care is management of symptoms of advanced disease at any stage of life when people are pursuing aggressive or curative therapies. So for an advanced cancer, metastatic cancer, or for COPD, chronic obstructive pulmonary disease, or heart failure, that kind of thing, there's things that sometimes they cannot be cured, but they can be managed, and sometimes people, like with cancers, they could be cured, and people are seeking that treatment. Yet they have symptoms of that advanced disease that need to be managed and palliated. In the middle of the night, they might wake up, they might be fearful, maybe they have a shortness of breath or some pain that's new, and they say, I don't really want to, it's not something I need to go to the emergency room for, and I don't want to and sit there all night and wait or whatever. I just need somebody to talk to. So we supply that. We supply a nurse 24 hours a day, 7 days a week for symptom management. So they call us and they say, I have this new pain. So if we can work on things over the phone, if it's the middle of the night, we try. But if we can't, we have a nurse in that area on call, and that nurse will go out and stay with that patient till the symptoms are managed. And it's such a comfort for the family and for the patient to know that they can pick up that phone and talk to a nurse anytime.
Right.
So also for management of symptoms, we work closely with the doctor. We have medicines in the home that we can work with, that we we know what the prescription is, but we might not be using them at that time or in that dose. We might have a range, but they can call us, and in the middle of the night we have our computer and we can look and say, we can give you this dose of medicine if that dose isn't working because the doctor said that we can give it again. So we work with the family to get them as comfortable as possible without having to do that ride to the ER.
Or even call the doctor's office, because you're kind of handling that for them.
Yes, exactly. We're the person that can make those calls and make those decisions for the family and comfort them.
So if you had to say, like, what's the difference between hospice care and palliative care? Is there a simple kind of it's pretty simple. There is a little bit of a gray area, but essentially palliative care is when people are seeking active treatment. Now, if the doctor has said there is no more treatment for you that can cure this disease, or if the patient says, I've had enough, I don't want to do that anymore. So when you think of, I'm sorry to interrupt you, but for active treatment, I'm just trying to get to the viewers of What would active treatment be? Like
Chemotherapy.
chemo? Okay.
Chemotherapy for cancer. Sometimes it's balancing a lot of cardiac medications for heart disease.
Okay.
It's for respiratory symptoms, for COPD or other things, sometimes it's just going back and forth to the hospital, and the respiratory therapists are just giving treatments and BiPAP and CPAP to help that person breathe better when we can do all that at home. So the doctor might say to us or say to the patient, you can get this done at home. This is what we're doing for you here. You don't have to come in, you can go home. So it's and part of it is the bridge and understanding, and we support that and we help that because it's a shock to hear,
Sure.
oh, there's nothing more that can be done.
Or sometimes people make their own decision. I am so done with this.
Yes, but then they're there and that feeling of abandonment might come in. Now what? I've just told my doctor I don't want any more treatment. He's going to walk out and I'll never see him again, and now what do I do? And I've experienced that personally, having had a bout with cancer and choosing not to necessarily do what the doctor said. So I understand that feeling of abandonment. Well, I still want to be treated. So we step right in and we work very closely with the cancer center and with other doctors. And we step right in and say, your doctor's still going to be there. We're still going to be there for you. We're going to treat all your symptoms. Now it's really about not worrying about coming back and forth to the hospital. With palliative care, maybe so going back and forth is necessary. But now it's more about what's your quality of life? Let's get the anxieties down. Let's just say what we want to do is get you as comfortable as you can, and when we're finished with you, we want to look at your family members and get them as comfortable as we can with your choices. And then after that, we can get you to really enjoying your life instead of bouncing back and forth to the hospital, worried about everything. What about this treatment? What about the side effects? What about everything? We're like, we got you. We got you covered. Go get that good book. Go to the library. You want to go to the beach? You know, that kind of thing. So
the curative treatments, that would be the palliative. So somebody's still engaging in curative treatments, but the palliative piece would be maybe they're really nauseous because of whatever the treatment is, and so that you would still be available to help them through that part
exactly,
of it.
for the symptom management. And I've merged them a little bit together. It's hard not to, but that's for the symptom management. And they don't even, frequently, it might just be for pain management, and it might not even be, say, an illness that might result in a terminal illness. But sometimes we just are called in for advanced pain management, and we have to do a few consults with palliative care to palliate symptoms. So think of palliation as palliating symptoms while you're getting treatment. That's the simple definition. And then when treatment is, for curative treatment is stopped, for one reason or another, that's when we transition over to hospice, although hospice needs the criteria of 6 months or less, according to the doctor, if your symptoms, if this disease was allowed to take its natural course.
If it keeps on going the way it's going.
Now
my best guess is,
it's hard to say. Nobody can say when things are going to happen, and we've had situations that have gone on a lot longer. We say, now it's time to really realize all we're living for is today, that's all we're all doing. We don't ever know when the bus is coming or anything, but when we wrap ourselves around, when we get that idea, and we really get that idea, and we realize we only have the present moment, it becomes that much more valuable, and we can really live our lives in a different way, forgiving people faster and being more in the present moment and enjoying things like even being on TV.
Nice. And a beautiful day like we've had today.
And a beautiful day, yeah.
So that's a good explanation of the two differences. And is it usual that patients might be taking advantage of the palliative care services before they transition over into hospice care? Is that really sort of the best design?
It's the best design,
But not
and
everybody gets to
actually
do it,
the
or-
Commission on Cancer, which is the accreditation group that accreditates cancer centers, has new standards, and they involve palliative care sooner because they realize that it's very important in the treatment of cancer to have that kind of support and to know that that's available. And therefore, in the whole continuity from diagnosis of cancer, advanced cancer, that patients know that this is available to them. They don't have to take it, but they know that they have availability 24 hours a day of a nurse to manage their symptoms. The Cancer Center has said this is a real value to patients. So we're working with the Cancer Center to develop on those standards and work with the oncology nurses to have this flow more smoothly. It's a safety net that some of the patients aren't aware that they have, and they know even if they don't want it right now, it's there for them whenever they do want it.
Right.
So they never feel that sense of abandonment, that if I make a choice or if the doctor tells me something that's not good news, I have a support system that's going to be with me, and I'm going to have dignity even if I can't speak for myself, and I'm going to have somebody to set things in place. Right. We look at more so than the medical community now, we look at different kinds of pain. We look at not only physical pain, but we look at spiritual pain, we look at emotional pain, and psychological pain. So I can give you examples of any of those. Yeah. Well, the spiritual pain is, a lot of it is feeling abandoned by God. Maybe it was through a religious process or through the veterans. We have sometimes in the war, they feel as though they've had to do things that were ethically not something that they would normally do. And they need to be at peace with that. They struggle with that. So there's a struggle there that we can address, and we have chaplains that are skilled in that, non-denominational. Emotional pain, and I can understand this, is I have cancer and I'm okay with that, but it's killing me to think about telling my daughter, and that is real agony for me. And I can understand, if someone feels that way, I could understand that. Yeah. And we say, this person is very anxious. They're not in pain, physical pain from their cancer, but they have a lot of emotional pain. We have social workers that can work on that, and we work as a team together to get that to come out. And I also know that family members may not want, like a daughter will come in and say, oh, my mom's really strong. She's got it all together. But I have it all together for my daughter too. But when a hospice nurse comes in and says, do you have concerns? And there's a one-to-one there, and somebody that I can kind of let it all out to, or a social worker, I would tell them things that I would not tell my daughter. Right. So we're very aware of those things. So we really want to be there to get that out, get those fears out. If somebody says, I'm scared, we don't want to walk away. We don't want to say, I don't have time for this. We say, what are your fears? Tell me what's going on. And it's just a peace comes over, when people have said what they need to say, and we say that we'll take care of that, or we can help with that, or, we'll work with that and understand it. So,
and I hear that from some of the nurses that will say, they've talked to someone's daughter or son who says, I never heard that story before, because the patient's more apt to freely share something with not even a stranger, a little bit of a stranger than their very own, because of the pain or the emotion that's attached to that.
It's true.
Yeah.
I remember when my mother passed away, I couldn't talk about it for a long time, and then the first time I said it to somebody was the checkout person in Marshall's. I was like, my mom died, and she's like, I've lost mine for 12 years, and I felt that bond with her, and I knew I could walk away, I would never see her again, or maybe not, but that was my outlet for me. It's the freedom for that. So we can supply that, but yet we understand that patient caregiver bond is the most important thing, and to develop that with a patient is is primary, so that that patient knows that they can trust us, that we'll be there, that we'll work on things, and we'll do what's humanly possible to get accomplished what we need to. And that whatever it is that happens, it's like childbirth, we can't promise a smooth transition all the time. There might be lumps and bumps in the road, but we can say that we're going to be there, and we're going to make it, we're going to make it happen, and you're going to be okay.
Yeah.
Yeah, yeah.
So it sounds like there's a lot of people involved in the care of someone. So you have what would be called an interdisciplinary approach to the care. Do you want to talk about the different players that are in there?
That's part of the hospice philosophy, and palliative too. But we have a team that works together, and I mentioned them, the chaplain, well, it's the doctor. If you kind of envision a center, and that's the patient, and we have all around the edge of the patient, we have the doctor, we have the nurse, who's a case manager, and we have the management staff, the management team. We have team leaders and things like that that manage calls in the office, and we have our chaplain and our social worker, and we all work together. So we meet as a team once a month to talk about this patient, and more often as needed, to talk about the concerns of the patient and the family and how everything is going. And it's really beautiful the way that it works. It helps to keep the anxieties low, and to make sure that the whole team that's working with the patient, including the family, is all on the same page.
Oh yeah. So there's a lot of people involved in the care.
Absolutely.
Specifically.
Oh yes. Absolutely.
So they get all the benefits.
Yeah,
Yes.
yeah. And while I have a moment, I just wanted to talk a little bit about healthcare proxy. Okay. It's an important thing for people to choose a healthcare proxy, and to choose someone that can speak for themselves when they can't. Okay. And it's someone that can speak your wishes, not their own wishes, when you cannot speak for yourself. Okay. And one of the things that we have as a tool is this called 5 Wishes, and it helps to guide the healthcare proxy and the patient as to how to speak for the patient. Okay. What might you want in these circumstances, or what might you want in those circumstances? It's a tough little form to fill out, but we say do it at Thanksgiving, around the table, and you can kind of, make light of it, enjoy it. Yeah. And people are thinking this might not ever happen to me, but it does. And to know that someone's there and going to do what you want to do is a wonderful thing. So you do it. The healthcare proxy takes it, it's gone. But we see the instances where these things haven't been done, and it's like, oh my gosh, I thought this would never happen. Yeah, and it comes on so suddenly. It comes on suddenly, or somebody says, gosh, I have no idea what they would want in that. Yeah, so we take it upon ourselves to say, no, it's a little hard, but fill it out. So I brought one for you.
Oh, good.
There
5
you go.
wishes, there it is. Should look familiar to some people.
Yeah. Oh, yes. They're around, and they're actually quite popular. I bring them around in the hospital all the time and leave them off.
Does this have to be notarized then to make it official, or
no?
It goes with the healthcare proxy form that you fill out at your doctor's office?
Yes, it goes with the health. It's a guide. It's not a legal document, but it's a guide for the healthcare proxy to use.
So they have a toolkit.
So yeah, there is
they can't remember anything.
The healthcare proxy
everything's come undone. Yeah. Wow. Well, thank you for that.
You are welcome.
Now, I know people think that palliative care, hospice care is just for, not all people think, but cancer patients tends to be the one everybody hears about. But there are other diseases or progression of diseases where this is palliative would be handy.
Yes, we have a set of criteria that we have to use for, well, again, the palliative care. It can be any advanced disease that needs symptom management. We tend to try mostly to do palliative care that are what we call bridging to hospice, and we can see that the progression of disease, if it's going to go its natural way, would result in hospice within a short period of time. Again, but we can do palliative care for anybody with advanced symptoms to manage their symptoms.
So you might see so you'd have cancer, you might see heart disease or
Yes,
pulmonary,
yes, yeah,
some of the other.
right.
Okay.
There's any disease that the doctor chooses, and then we look for different things like weight loss, inability to ambulate. Dementia is a big one, and it's when to know when to bring the patient on, and for quality of life and that kind of thing.
Okay.
So we do have to look for that decline, and when we can match it up, then we can bring them on to hospice.
Okay. Now, we only have about 2 minutes left, but I wanted to touch on just quickly so that people are aware that these are benefits that are covered under the business side of it. So the insurance programs, Medicare covers.
Yes. Medicare
both.
will cover palliative care. Palliative care and VNA certified, which is just, change of
Regular
blood
home
pressure
care.
medication,
Yep.
home care. Palliative is a part of that. And then hospice has its own Medicare benefit because they feel like you're not spending a ton of money trying to seek out treatments and that kind of thing. So let's take that money and we can buy equipment to go in the home, and we can pay for more services for you. We can pay for a home health aide to come in and help you get cleaned up. And so Medicare will cover
All of that.
most of the hospice expenses.
Yeah,
yes.
that's great.
Yeah.
So is there anything that we haven't talked about that you want viewers to know about hospice or palliative care?
Well, I think we covered a lot. I tried to get most everything in there that I needed to. I just want people to feel very comfortable that it is 100% of us are going to die at some point in time. I know it's hard. Yes, it's a hard thing to think about, but I would like people to just think about that a little bit and know that they have control over their quality of death as well as their quality of life, and that we can help with that and help them create that at the end that they're comfortable with.
That's a good message.
Yeah.
Well, thank you, Donna, for sharing your expertise. It was good information. I appreciate it.
Thank you, Jean.
All right.
Yep.
And I'm Jean Sarnowski, wishing you good health and good health care.